So what you need to appreciate is that cardiovascular disease is common. It's probably the leading cause of death to cancer. It's a condition that starts almost in childhood, so intervening as early as possible makes the most sense. This diagram I use every day when I'm talking to my patients because it shows the entire lifespan of this condition from nothing, from health, right through to obstructive coronary artery disease on the right-hand side, something that causes angina. And of course, this can be silent right up until that middle point where you've got a vulnerable plaque with a thin cap that can rupture, causing a myocardial infarction caused by a rapidly developing thrombus. So that's where statins and aspirin over many years have had a role in both stabilising that plaque, pushing it towards the left, and preventing the sudden accumulation of a platelet-rich thrombus. The calcification that you see around that is not the disease, it's the consequence of it. So it's a multitudinous causes that I've listed there on the right. LDL cholesterol's always been at the top of the pack because we've got clear treatment guidelines and it's been proven to be causal. But we've got an emerging epidemic of diabetes, obesity that's driving that. And I put there hypertension, ageing, smoking, and then the fact that we now know that somewhere between 40 to 60% of it is genetic. The bottom there shows exponential growth curves. Those are coronary calcium scores done over time, and unfortunately we all sit on one of those curves. You just don't want to be on the steepest one. And if you think about it, intervening early at around 40 to 50, changing that trajectory is going to have a really big impact 20 or 30 years later. So we're looking out into the future when we're treating this condition. In the middle there's a CT coronary angiogram showing both calcification and plaque, soft plaque, that's not visible on a coronary calcium score. Calcium scores are good, you can obtain them. We would prefer that you order them and don't ask us, does the patient need a calcium score? We'd like you to do them and then send us the patients in whom you're concerned with the result. On the bottom right there is a carotid intima-media thickness ultrasound scan. That's a high fidelity ultrasound scan, and that measures the actual intima, that salmon pink layer that you see on the far left, which is normal, but then gets thicker over time as the growth of the condition progresses. It's not quite as good as a calcium score at predicting risk. And then across all of these is inflammation, and I bring this up because we know that it's been part of cardiovascular risk for a long time, but we haven't really known how to manage it. We've had CRP as a tool, but it's a bit of a blunt tool. Most, unfortunately, our calculators overestimate risk, and that includes the predict risk that you use that Rod Jackson's produced. And the idea of over-prediction is not to miss cases, but that does mean at a population level, there's the potential for over-treating people with lipid-lowering therapies and other preventative therapies. So we're always moving towards more accurate methods of calculating risk down to the individual person. Now, LDL cholesterol is causal. There's no doubt about that. There are these relationships, the red dots there are clinical trials that over time have pushed LDL cholesterol lower and lower and lower. Our guidelines say less than 1.8 if you've got proven coronary artery disease, but in fact overseas, in Europe and elsewhere, the aim now is to get it under 1.4. And in the Indian guidelines just released in the last few months, under 1. The blue line there with those dots are genetically encoded cholesterol genes, mostly loss of function mutations, showing a very clear relationship down to almost 0, though the lowest level probably we should aim for is about 0.4. Statins were the wonder drug for 20 or 30 years, but unfortunately they do have their downsides, and again, if produced or delivered at a population scale level, you will see individual cases of type 2 diabetes that have been stimulated or caused by them. Again, there's no doubt that that is the case because there's a gene or a genetic relationship underpinning that. This doesn't happen to all patients. It's probably those that have some predisposition to type 2 diabetes who are a bit overweight. And then there's also the concern that it makes people less active because they're a bit stiff and sore. Now, I'm not saying that statins should not be used. I'm just saying that you've got to weigh up the cost benefit to each patient in terms of what you might be doing to them over 20 or 30 years. The odds ratio for developing type 2 diabetes is somewhere between 1.3 and 1.4. This recent study compared high-dose rosuvastatin and atorvastatin and showed that that concern was particularly the case with rosuvastatin compared to atorvastatin. So I myself am very cautious about the use of high-dose rosuvastatin and only use that in selected cases of people with heterozygous familial hypercholesterolemia. It also increases the risk of cataracts. So I mentioned here SGLT2 inhibitors. They aren't at the moment indicated for the use of cardiovascular risk, but it's quite likely that they'll enter that space. They've rapidly emerged as the new wonder drug because they treat not just type 2 diabetes, but also heart failure with preserved ejection fraction, chronic renal disease, and you'll probably hear a number of people talking about them today. Interestingly, the discovery of these agents came from something that was found in apples called fluorescein, which is in the apple bark, skin of apples and leaves of apples. If you eat 2 apples, you're eating about 2 to 3 milligrams of an SGLT2 inhibitor. You can't eat too much of it though, because it inhibits both 1 and 2, and it will give you diarrhea from the 1. But apple cider vinegar has quite a lot of this in it, so you can get a modest effect, and that's probably where the health tonic consequences of apple cider vinegar have come from. So SGLT2 inhibitors appear to be anti-aging. Now this is not an indication for them, but this is going to keep happening and turning up in your presentations. The other big drug that's emerging in this area of cardiovascular risk reduction are GLP-1 agonists, and unfortunately they are not available in New Zealand. I tried to prescribe one this morning and couldn't even access it for someone with diabetes. We can't get our hands on Ozempic or Wegovy because 2% of Americans are injecting themselves with it, and they're soaking up the entire world supply. There are downsides to this too, and you can see down the bottom there in yellow that there's an increased risk of chronic pancreatitis, bowel obstruction, biliary disease, and gastroparesis, which is haunting our anaesthetists who see people with these medicines. And we're only at the very beginning of these because there are now triple agonists that cause quite profound weight loss. And this has been great news to the drug companies that are now worth trillions and trillions of dollars. Probably the most remarkable advance in this area has been colchicine, the use of old medicines that are very cheap. And colchicine, when used judiciously, reduces risk by a substantial amount, a hazard ratio here of 0.7, and this has been replicated in a number of different randomised clinical trials. Really interesting is that there is a subset of people who probably respond most to colchicine, and these are people who have something called CHIP in their blood, which is a precancerous condition that results in eventually, for some, myelodysplastic disease. Unfortunately, you can't see this on a full blood count. It requires deep next generation sequencing of peripheral blood to see it, but tests for this will be coming, and 20% of patients over 70 have CHIP. As I say, some of them will get myelodysplasia, but 20% of people over 70 have a substantial increased risk of coronary artery disease that will probably be manageable with the use of colchicine. You will see some of the cardiologists using colchicine, so that's something just to keep in mind in people who do not have gout. Your patients will probably be asking you about lipoprotein(a) and ApoB because they read and watch things from Peter Attia and others on the internet. Lipoprotein(a) is also known to be causal, as was LDL cholesterol. It's a fixed thing that you only need to measure once in a lifetime. It's highly genetic and hereditary, and it's even more pronounced risk than LDL cholesterol. Unfortunately, there is no treatment that can be directed towards it, though there are clinical trials on drugs that are. On the right there's a natural product that includes berberine. So berberine and niacin do reduce lipoprotein(a) and LDL. And this natural product, amolipid, is actually recommended. It's got meta-analyses behind it, and it's got berberine, red rice yeast, and a couple of other things in it. So it's a very cheap option for people who can't tolerate statins. It's not an expensive test, lipoprotein(a). It's only $13. ApoB is better than LDL cholesterol at estimating risk, but it's so strongly correlated with LDL that most of the time you don't really need it. It's only in about 10% of the population where ApoB will distinguish risk different to an LDL. But again, your patients will ask you about that. In a subset, a very small number of the population, risk is very high, and they have often familial hypercholesterolemia. That can be identified if the LDL is over 5 and they have a family history of high cholesterol and premature coronary artery disease. Unfortunately, less than 10% of people will be diagnosed with this. Most people think, well, you just put them on a statin, but it's not just that, it's about their children and their brothers and sisters who haven't been diagnosed yet. We also, not only can we see this at a genetic level with these mutations that cause familial hypercholesterolemia, but we can look across all genes and estimate polygenic risk, and you may hear about that from a few other speakers today. So if you looked at 100 people who've come to coronary care with myocardial infarction, you'll find 2 of those people have familial hypercholesterolemia. That's how common it is. You'll have 17 who have high polygenic risk. It's equivalent to having a single gene mutation, and then you have one person who has both monogenic and polygenic risk. I'm just very mindful of the time here. Polygenic risk scores are coming. They're not recommended yet by any societies that I know of, but they are probably more powerful than most of the other risk factors that we know of, in addition to those risk factors. Here's a young man who has an LDL of 8, who sees me in private, whose grandfather had an MI and died at 37, a maternal uncle with bypass surgery in his 50s, and another uncle with 8 stents at 40. He has not only a mutation in the LDL receptor, but also has a high polygenic risk. So he was that one person at the bottom who had a 6-fold lifetime risk of disease. He's now 30 and he has plaque in his arteries, and I can only just get his LDL to the upper limit of normal on rosuvastatin 40. Now, the rest of his family living in Australia can access this, a PCSK9 inhibitor, but not in New Zealand because people have to pay for it. Here's a patient who sees me at Ascot. So what is the future? Okay, very quickly, the future of cardiovascular risk assessment, it's machine learning and artificial intelligence. This is a woman who sees me who has an LDL of 5, so there was a suspicion that she has familial hypercholesterolemia. This is her ECG, which appears normal. However, a machine learning algorithm said no, 99% probability of coronary artery disease. She had a calcium score above the 95th centile, and she has a gain of function mutation in the PCSK9 gene. So for her to obtain that medicine that I mentioned before, the PCSK9 inhibitor, this would be a cure for her. The PCSK9 inhibitors are here, so they've been here for a few years, and the most recent one is inclisiran. Unfortunately, that price is wrong. That's what I thought it would be. It's $8,000 a year. Very few people can afford that. Pharmac does not fund it. It should be given to people with heterozygous familial hypercholesterolemia. It's a small interfering RNA treatment that's taken as an injection every 6 months. So adherence, no problem. Once every 6 months, you're given an injection. It's a small, PCSK9 is a small protein that binds to the LDL receptor and causes it to invaginate or be consumed into the liver. You want LDL receptors because they're a mop for LDL. So PCSK9 inhibitors get rid of PCSK9 and you end up with more LDL receptors. These are very clever agents. They're injected in the skin, but they target the liver like nanobots. What's the future? CRISPR-Cas9, and we are doing the first clinical trials in New Zealand of this, where we can permanently turn off that gene PCSK9, and we've been running that trial for 2 years and proven that it works. It'll lower LDL cholesterol by 50% for at least over a year. So the future of management of this for people with very high risk, instead of them coming in and out of hospital, being non-compliant, having stents and bypass surgery, will probably be a single treatment that lowers their LDL cholesterol for the rest of their life using gene editing, essentially genetic engineering. 1 minute to go. So, in conclusion, coronary artery disease is a lifetime chronic condition that starts from birth. Intervening as early as possible is what counts, but choosing your patient carefully is what's important because statins can cause type 2 diabetes and other issues. So be careful and monitor HbA1c over time in those on high doses. You can use PREDICT, coronary calcium scoring. Please use that at your discretion. Carotid intermediate thickness ultrasound scan, and CT coronary angiography is really for people with symptoms. It's not a prediction tool, but in the future, very soon, we'll be using machine learning tools and genetics. I've talked about LDL cholesterol, obesity, GLP-1 agonists, hypertension I haven't really touched on, aging, smoking. Briefly talked about CHIP, this precursor cancerous condition in the blood. We've talked about monogenic and polygenic risk, colchicine you'll see more of, it's cheap. Give it to people who seem to have inflammation, who have multiple vascular events, and SGLT2 inhibitors. Atorvastatin is probably still the preferred agent, and only use rosuvastatin when absolutely necessary. And PCSK9 inhibitors are available for patients who can afford them. Or if you have a really high-risk person you're concerned with, refer them please for a clinical trial. Thank you very much.